So good morning, good afternoon, or good evening, depending from where you are joining us. Tonight, the IVPN NeuroPsychiatry, in collaboration with Jensen, is organizing this educational activity entitled The Pharmacoeconomics of Chronic Diseases, during which Dr. Sara Dallal, Dr. Samer Makhoul, and Dr. Ahmed Shatila will highlight the importance of pharmacoeconomic in chronic diseases through case-based applications from the neuropsychiatry field. In fact, chronic diseases management is a systematic approach to a health condition or a healthcare intervention that organizes preventative, interventional, and care approaches through the continuum of care and which measures outcomes in terms of populations and not individuals. And disease management advantage over the current component system is that it stresses prevention over acute treatment of a chronic disease. And usually patients with better control of their chronic disease will likely have a decrease in the use of emergency room and inpatient hospitalization services, thereby improving clinical outcome of patients and decreasing the economic burden of chronic diseases, not only on patient and their family, but also on society and healthcare systems. To achieve all these goals, disease management uses pharmacoeconomic evaluations and outcome measures to provide information that helps build formularies and clinical practice guidelines. Tonight, we will learn about pharmacoeconomic evaluation in chronic diseases. But before starting, let me thank Jensen for sponsoring this educational activity. Our first session will be delivered by the expert in the field of psychiatry, Dr. Samer Makhoul. Let me introduce Dr. Makhoul for you. He is an experienced UK certified consultant psychiatrist at Al-Reem Hospital and the co-founder and CEO of Reem Neuroscience Center. Dr. Samer has a wide and rich experience gained from his years of training in the UK, where he has obtained the membership of the Royal College of Psychiatrists in 2006 and a higher specialized training in adult psychiatry and addiction in 2010, and a fellowship as mark of distinction and recognition of contribution to psychiatry in 2018. Dr. Samer has complemented his training with a certificate of psychopharmacology from the British Association of Psychopharmacology, as well as a postgraduate certificate in the autism from the Sheffield Hallam University in the UK. He is an aviation specialist and approved by the General Civil Aviation Authority in the UAE and a specialist in aeromedical examiner. Dr. Samer has more than 22 years of experience in psychiatry between the UK and the UAE, as well as a multiple management position over the year. Dr. Samer has been a regular speaker in national and international conferences and has multiple publications in international medical journals. He plays an important role in raising awareness about mental health in our Middle East region. Thank you, Dr. Makhoul, for joining us tonight. I want to notify our audience that there will be a minor change in the agenda. We will start with Dr. Makhoul presentation and the clinical application of pharmacoeconomics on depression and mental health. Then another lecture about the pharmacoeconomic application in multiple sclerosis disease, and then Dr. Sara Dallal will join us to give us or will teach us about the pharmacoeconomics models and the role of pharmacists in applying this model and their importance in the healthcare system. Dr. Makhoul, it is our honor to have you with us tonight. You are the most welcome and the floor is yours.
Thank you so much, Maya. Thank you for the beautiful introduction. And thank you for the audience. I can see there's more than 300 people. So to have all those people attending today is a great honor. I'll just share my screen. And here we go. Share and voila. Okay.
Yeah, we can see your slide.
Yes. So to start with, having a psychiatrist giving a lecture for this wide audience is very important for us, because I think, we're trying to raise awareness about a lot of stuff, and, we want to raise awareness about mental health. We're going to talk about the chronic part of it. We're going to talk about depression and schizophrenia. And I'll be hoping to kind of make it a little bit more interesting for you guys, and to be quite, let's say, different than the normal lectures. Okay, so we're starting with depression. So talking about depression and why it is important. So we try to give you some numbers. So the depression, according to the WHO, is a common mental disorder. Globally, there are 5% of adults suffer from depression. يعني as we speak, there's 5% of people suffer from depression. There is 300 people, like, now in this talk, 5% of those, there's 15 at the moment, or maybe more, might be suffering from depression. Why this is quite important? Because depression is the leading cause of disability worldwide, and is a major contributor to the overall global burden of disease. I'm going to talk a little bit more about that in the coming slide. Unfortunately, and whenever I go and do a talk or TV interview, and I say, unfortunately, women are more affected by depression than men, everybody say yes, of course. I think there's a big part of that is kind of hormonal changes, that the woman has to go through, especially with births, pregnancies, and menopause. Why also it is important? Because, I'm going to mention a few numbers about suicide. Every year, nearly 1 million people commit suicide, and 10 to 20 million attempt suicide. The number of suicide cases in mortality and the impact is quite huge, And, we always try, especially in this part of the world, we always try to say, oh, suicide, no, that's not us. It will never happen to us. No, this is the disease. It's not about, anything else other than the disease. Yes, there's some protective factor when you have strong family connection, when we have religion is a protective factor, but they are protective. They are not absolute factors that will stop you from committing suicide. So what is depression when I talk about depression? So let's try to make it simple. Changing in eating habits. So you might be eating more, or loss of appetite, losing weight, feeling of sadness, unhappiness, hopelessness, pessimism. You might be irritable, agitated, restless, or frustration, such an inability to sit still, pacing or, hand wringing. Loss of interest or pleasure in activities that were once pleasurable. So you might be enjoying to go to the cinema, and now not anymore. You might be enjoying to go play football, going out, shopping, anything, you might be enjoying, but now, no, I'm not interested, The intimacy and the sexual drives, that would go down, so the libido would go down. You might start to feel guilty or sort of worthlessness. So the feeling of guilt sometimes goes back, like, I'm feeling guilty about something I've done 20 years ago. Is unfounded or exaggerated, but you start to feel guilty. You feel tired, lack of energy, fatigue. Those symptoms are almost, we see them in every patient. Difficulty in concentrating, thinking, decision making, or remembering. Not sleeping well, insomnia. In some cases, we might see the opposite: increased sleep. Staying in bed all night long. Of course, when we say about depression, we always think about crying, but you cry for no apparent reason. You're just sad and crying. And very interesting is we see unexplained physical problem, headaches, pains, cramps, backaches, digestive problem. So you might have a lot of symptoms that they are unspecific, physically somatic symptoms. Why chronic? Because we have a lot of reasons. One is suboptimal treatment initiation. Only 1/3 of newly diagnosed patients are receiving treatment. So we don't start treatment, so we don't treat. So that's why it's chronic. So we have a disease that we only treat or only start treating 1/3 of the patients. So I've got 2/3 that they are not treated. Stigma. Many patients delay seeking treatment or do not fully adhere to antidepressant regime. The stigma is huge. We have people saying, yes, I want to be stronger. I want to be, to depend on myself. I don't want things, to change my personality. The amount, even we go with, sometimes we take religious reason. We think like, okay, if I pray more, I would be feeling, no depression. Of course, we're not saying about spiritual is not important, but at the same time, we don't tackle other diseases like MS. We say, I'm just gonna pray. We pray, we all of us are religious, but we look at also having treatment for the biological disease, which here is the depression. Start low and go slow. Practice guideline, they talk about, very slow initiation, and that tends to be very chronic in response, and people stay on suboptimal doses of medication. You cannot imagine how many people I've seen they are on half of the effective dose, and they've been on it for a year, and they're complaining it's not working. So this is how depression becomes chronic. So as I mentioned earlier, we got to say about, chronicity, how it affects that. So the major depressive disorder is the leading cause of disability worldwide. In 2015, about estimated 40.3 million cases of depressive disorder were reported in Europe. We're talking about, 40 million cases in Europe alone. The number of people living with depression globally between 2005 and 2015 increased almost by 20%. Is going higher and higher and higher. Up to 50% of chronic sick leave is due to depression or anxiety in Europe. We're talking about, this is where the disability comes on. We're talking about half of the people are saying they are sick, it's because of depression or anxiety, And we know the older we get, the most likely to have depression, even though we have an alarming higher number of cases of a younger population in recent years. So worldwide, we talked about Europe. Worldwide, the estimated number of the patients with depression that are suffering 300 million. We're talking about like, a number that is that huge. The worldwide cost on the economy in depression and anxiety is about $1 trillion. This is, I think, I don't think I've ever seen a number like this within any disease, So we're talking about an impact that is that huge on economy. And over 90% of people who committed suicide had a diagnosis for mental disorder, and depression obviously is one of the main ones. So what is depression and what causing the impairment? As I said earlier, we don't treat it well. So we have lack of appropriate treatment. So most people, they do fail to antidepressants, when we give them. So we're talking about a lot of treatment resistance. And we know that, so those cases, they need to develop further treatment. And most of the physicians, psychiatrists, and everybody with treat mental health, they tend not to go to optimized treatment or switching medication. And we know there's a high rate of recurrence, and because most people, they are not compliant or they stop medication for the many reasons I told you about earlier, mainly stigma. And we know once we have the disease, more than twice, it's almost certain that you're going to suffer from it all your life, So we're talking about 90%, and they talk about almost 100% in some of the studies. So it is a chronic disease. It keeps repeating the same episode or worse episode over the years if we're not having treatment. So what is the treatment? Obviously, we want all to talk about psychological treatment and behavior therapy. It is a gold standard. That's what people expect. Obviously, not this type of. This is more of like psychoanalytical therapy, and that's what people think about. But there's a type of a treatment called cognitive behavior therapy, which is very good, that we use. So that's one kind of treatment, mainly for the minor cases. It's quite good with relapse prevention, but there's always a lot of publicity that is negative about medication. Even doctors, healthcare professionals, they keep talking about, oh my God, antidepressants, they have little effect, or all 1, 2, 3, 4. However, all the data, even with this study. So this one goes to the really to the what do you call it, to the headlines. However, the counter of this one, because the way that they did put this headline was misleading, and actually they showed that this was not the case. For example, when this study came in with this, because they looked at the very mild or a pre-depression. So in this kind of studies, they showed if you take medication or if you don't take it, doesn't make any much difference because there's a high rate of people getting better, while this was not actually a proper clinical depression at the time. And there was a lot of studies that counteract this one. So in general, with medication is we have antidepressant, without going into too much details, I'm giving you a very old studies that looked at medication, compared them in a very strong meta-analysis, that they looked at this, and they found 4 medications that they are quite common: mirtazapine, venlafaxine, estropan, sertraline, and and they are very effective. And there are 2 with the least side effects are sertraline and escitalopram, and actually those are the top 2 medication used worldwide. So we know it's quite commonly used, and we know they're quite safe medication. So specialist treatment, now we are moving forward. I think that's very important, So we're not only thinking about just normal therapy, or we're talking about normal medication. We do have the very old gold standard super effective treatment for depression. That is the life-saving. It's called ECT, even though there's a lot of negative publicity over the year, but this is probably one of the most effective treatments that we have. And we have a newer kind of medication, not a medication treatment, like deep transcranial magnetic stimulation treatment that offers significant result into depression, anxiety, OCD, or even smoking addiction. And as you can see, it's a very simple machine that you come during your lunch break, you have the treatment, and that is, quite effective even in the treatment resistance. So we're talking about treatment is moving forward with the minimal side effects. All we have, as we talked about, there's a 60% of people they're having treatment resistant, and esketamine has been a new treatment also that is given to patients, under supervision. That is a nasal spray, and help response between 50 to 70% of the people who are responding to treatment. Actually, I have used this one from the national newspaper of one of our colleagues here in Abu Dhabi in Sahha, Dr. Nahida, who is one of the people who are treating patients with the new medication. And our center at Tarim Hospital is the first center of excellence in the region. So we're developing a lot of treatment. There's a lot of hope, and we can really fight this chronic disease. And actually, we're succeeding in this. Moving to schizophrenia. So schizophrenia is what kind of people usually talk about, always about mental health. And, that's the impression when we're talking about, mental health and psychiatry. People think about schizophrenia as a first treatment. So what I'm going to try to do is I'm going to try to move from the normal way I talk to you about the first disease, and I'm going to try to make it more of interesting to you guys. So I'm talking about this artist. He was born in the UK. He used to do sketches as a job, in the old days. And when his wife was unwell, he started to do drawing about cat, and then wife liked that and started to send drawing to newspaper, and they used to publish it. And there was he did win a lot of contests, and he becomes the national cat club president. So this is somebody who is interested to cats. He was admitted to hospital, to a poor mental hospital by his sister, diagnosed with schizophrenia. And then later on was admitted to a different hospital, a very famous name, in the history of schizophrenia of the patient. Keeping in mind, during that time, there was no treatment. So there was no medication invented, because the first medication was in the 50s, 1950s. And this is what he's used to draw. So if you can see the picture of the photos of those guys, they're quite nice. Actually, some of them are funny, but they're quite, normal, good drawing. Then, when he started to be unwell, if you can see what I have in here, you can see, compared to the previous one, look how nice the cats are, and then this is what the illness affects the brain, and look at, how he's seeing the cat, because this is how he's doing it. Moving to a further stage, if you look at this one, see how now he's picturing the cat. On the left is a dog he did draw, but this is kind of when he was more ill. So the drawing became like this. Furthermore, you can see now the cats are like aliens now. They don't, if I did not show you the first few photos of cats, you would say, and this is definitely not a cat. Furthermore, this one is very scary, especially on the left, at least, you can see like, it's quite, very disturbed images of the cat. And the last one, if I showed you this one at first, you would say, oh, that would be a nice rug in my house. You cannot even see the cat with this one. If you look at all this one together, so you can see from stage 1 to stage 5, the jack line of bright color became, emanating from his feline subject. Outline of the cast become more severe and spiky, and their outline persists well through the sketches. Abstraction continues, the cat's now being seen as made up by small repetitive pattern, almost structure in nature. And finally, we don't see any resemblance of cats. So if you look at this one, you can see how the illness would have an impact on the brain, and especially when there's no treatment, this is where the chronic part becomes of this disease. So the epidemiology of schizophrenia is not the first one, but it's in the top 10 causes of disability in developed countries worldwide. We're talking about 1% of the population, at any given time. This one is more men than women, at least, and we know there's risk factors, including gene, environmental factors, that are there. The main one, especially these days when we have a lot of increase of cannabis use worldwide, this is one of the main risk factors of causing schizophrenia, specifically cannabis rather than other drugs, So outcome of the first psychotic episode is beautiful. We're talking about 80% recover from the first episode. So what we see, and later on I'm going to be showing you some images, patients gets better, most of the time. However, they do relapse. And as we talked earlier about suicide, we're talking about suicide rate is quite high. So almost everybody would relapse. I'm not saying, we're talking about up to 80%. Some studies talk about 66%. So that we talk about this relapse is usually without treatment. The unfortunate news is people with schizophrenia, they die earlier. So we know that their life expectancy is reduced between 15 to 20 years, and that is much higher than cancer. So look at all the attention we do have for, for patients, with cancer, and actually schizophrenia reduces the life more than cancer, And cardiovascular disease is one of the main contributors, that's causing the deaths of patients with schizophrenia or dying earlier. We're talking about 50%, which is 10 times that than the suicide we talked about earlier. So when I said, okay, look at that, what happened? If you look at this graph, so usually first episode, people recover, they do well. And that's if you look at the bottom, you can, there's like 4 images of brains there, and we'll see the brain tissue loss with time becomes bigger. So once there's a pain tissue, there's, people become more treatment resistant, and they don't go back to the same normal of functioning as before. Treatment, the very important bit is, looking at this study, the differences in efficacy between drugs were very small. Antipsychotic differed substantially in side effects. So other than one specific treatment, which is called clozapine, this one is superior than everything else. All the others, they're almost the same, in terms of efficacy with minor changes. So I give an example, one of the oldest medication called haloperidol from the 50s, and olanzapine was one of the most common over the years. They're exactly the same. risperidone and aripiprazole, they're almost exactly the same. So all the medications, they always have a study that they're very similar. But I think the main thing that we look at the differences between all of them is side effects, and that what the impact also on the life expectancy. So thank you very much, for being with me today. And I think we might be able to do some questions if I'm correct, Maya.
Yeah, thank you, Dr. Mahmoud, for a very enriching presentation about the economic burden of depression and schizophrenia. So please allow me to take some questions. So the first question, does esketamine cause addiction?
Absolutely not. And I'll tell you what. So when we talk about esketamine, so esketamine is a molecule that is the main father of the molecule is ketamine, which is an anesthetic that used in surgeries, obviously for anesthesia. Esketamine is a very tiny dose. Is given as a nasal spray in. Yes, I have this dummy one with the patient in my office. So this medication is, if you can see, it's come with this. This one is like this one. So you cannot break that and getting out, and it's given under medical attention. So the risk of abuse is not there. The risk of addiction and tolerance is well controlled because it's a very low dose. It goes straight away through the blood-brain barrier, and that's how the quick efficacy we have.
Great. Another question, doctor. Do we have cost-effectiveness study between the newly approved esketamine antidepressant and the old oral antidepressant?
So I put it in a different way. So to have a cost effectiveness, it's usually when you do see which one is better. I think in the UK, NICE guidelines has been fighting a lot not to enroll esketamine. The way I look at it is totally different. So we're talking about this is treatment resistant. When I have more than 60% of patients, they are not responding to treatment. So this one has a 70% response rate in those categories. So the answer is, I don't use it as a first line of treatment. When I use people with treatment resistant and I get 3 out of 4 getting better, so I think that is very straightforward. It's support using treatment because we don't have in medicine this high rate. Is the cost is quite high. I do think it's going to go less in the years. I think that not the medication itself, the cost is high because the repeated attendance and seeing the doctor to deliver the treatment is where the increased cost rather than the medication itself. I hope this answer, but I think considering people not working, going back to work, that definitely is a good one.
Another question, in 2021, we have a new antipsychotic drug that was approved for schizophrenia, which is the 6 months paliperidone palmitate.
Yes.
So, and you mentioned in your presentation that usually schizophrenia die earlier.
Yes.
So, do we have or what was one of the outcome in the clinical trial of this new medication to improve survival? So do this new drug improve survival in schizophrenia patient? And we know that these medications are very costly. So do you think it's still too early to talk about cost effectiveness studies and pharmacoeconomic study for this product, but from your experience, do you think that it is worth the cost in using it as schizophrenia patients?
A beautiful question. I think, I've done so many talks. This is probably one of the most clever questions I have for quite a while, because, this is straight to the point, So we're talking about long-acting injection. Actually, long-acting injection improve life expectancy. We know the two treatments that they are effective are is clozapine, which have a lot of side effects, and the long-acting injection. They improve to live longer. It's much easier. I've been using the 3-monthly injection now for probably 4 years now. Before that, the monthly injection. It makes high quality of life. Definitely is a cost effective. We know each longer period one is more cheaper than the one. So the 3 monthly is cheaper than 3 of the 1 month. And keeping in mind, the main cost of healthcare is not the price of the medication, actually is the price of the care. So that reduces the burden on healthcare, indirectly, which definitely cost effective. I can easily say that. And I would say definitely once that is available, I'll be one of the ones to use it.
We have many questions, but not related really to economics, but rather to esketamine and the antidepressant use. So one of the questions, for how long does the patients or will the patient be using esketamine drug?
So most of the studies, the long-term studies, they talk about, 6 months, 1 year, how is that working? I've been using esketamine for 2 years and 4 months now. And I would say, I've had, let's say, half of my patients at least stopped within 1 year, and most of them, they're still doing fine. There were some that needed to restart on esketamine again, keeping in mind what I said earlier, the relapse rate is after 3 episodes is 90% or more. So we're talking about, do I use it as needed? So some of them, we restart using it in less frequency. So the answer is, I would not use esketamine forever because it's not convenient. But the good thing is when we restart using it, it was as effective as the first time.
Another question, how about the hospitalization cost for patients with depression and anxiety? So does it contribute or take a major part of the total cost of the management of depression and the anxiety?
So in the region, I think we are way behind in terms of hospitalization because we admit everybody. Hospitalization, it should be purely, and when I say purely, is for patients with severe risk of suicide or severe risk of self-neglect. So they are risk to themselves or to others. Anxiety is rarely the case. Depression, I would say very few of those. So they should not be anyway hospitalized. They should be treated in an intensive home care treatment, which is we don't have many in the region. So if I'm admitting people to hospital because of depression and anxiety, that is quite, not necessary to hospital. The cost will be high and the benefit will be low. So if I'm doing that, yes, I would say it's not good. However, I think those should be treated within the community. Cause of depression is making, the sickness and the sick leave, it would be the part of the big high of the cost.
Another question, what is the duration of treatment for SSRIs for depression? So how long do you give your patients, a patient diagnosed with depression, SSRIs? And whenever we need to stop the medication, please, can you explain to us how do we taper antidepressants? Okay, so two things with medication. One is the dose that gets you well, it's the dose that keeps you well. So the common practice is people, when they are, let's say, on escitalopram 20 milligrams, they see them well for a month, they reduce that. No, we need to maintain on the same dose. The numbers are, there's no exact period, keeping in mind it's a relapsing. First episode, we try to say 6 to 12 months with symptom-free. So they need to be well. Then we start the counting between 6 to 12 months. Second episode, 12 to 24 months. I would say third episode should never stop because the risk of relapse goes above 90%, So when you start to taper down, you taper down depending on the dose over 2 to 3 months. And you need to make sure they are not like in a very significant stressful environment. So if you're divorcing your wife or your wife is giving birth or whatever, is not the time when you are deciding to stop medication. If you are changing job, it's not the time. If you're moving house, it's not the time. So it has to be also the right time. Another question, do you recommend to give a combination of clonazepam with escitalopram or any other SSRI for the treatment of depression with anxiety?
So the answer is absolutely not. All the benzodiazepine are only given for a short period of time. Usually it has to be between 2 to 6 weeks. You can tell me, yes, in real life, we cannot always stop that. So that means we're not able to treat the illness well. Benzodiazepine are magical in treating the symptoms of anxiety, but they don't treat the cause of anxiety, and they cause high dependency. Clonazepam is not the worst of them because it's longer acting, but the answer is we should avoid unless if we're really struggling, but we need to acknowledge this is not a treatment.
Yeah. What is the incidence of having a patient diagnosed with schizophrenia and depression concomitantly? And in such patients, what would be the drug of choice?
A beautiful question. So we have high incidence, and we tend to see, historically, there was a diagnosis called, I think, post-schizophrenia depression. So people who, after they recover from schizophrenia, they get better, they have depression. So keeping in mind, depression goes into the serotonin, in the treatment, let's say area. Schizophrenia goes with the dopamine area as a treatment. So if I want to treat both, you can use some of the newer antipsychotics that work on both dopamine and serotonin, like lurazidone, cariprazine, brexpiprazole, those are new one, or the older one like olanzapine and quetiapine. When you go to medications that doesn't work on that both, then it won't be effective with the depression. However, starting an antidepressant is always easy, and that won't be for the long term because the core would be the schizophrenia, the depression would be, as a comorbid condition, so we can stop the antidepressant later.
And a final question, does the smoking cessation cause chronic depression?
Does smoking cessation cause chronic depression? I'm repeating the question is to think about it. I don't know why there's any link between this, so smoking cessation, it would improve your life, it improve everything. So, I don't know whether you're asking this question because you saw any study. I would say, even if it causes depression, I'll be more than happy to treat the depression and stop smoking. I think that should be, I do believe personally there shouldn't be anybody in the world smoking today, So if you are a smoker, just go straight away and stop smoking. And just a quick comment on that one. One of the two medications that help to stop smoking is an antidepressant called bupropion or Wellbutrin or Zyban. And also it helps with losing weight. So you might have, you stop smoking, mood gets better, and you lose weight. What else can you wish for?
Excellent answer and excellent session by Dr. Samer Makhoul. So thank you so much for being with us tonight and for your time and for answering all the audience question. And we will be moving to the next session about the economic application in multiple sclerosis. However, unfortunately, Dr. Ahmad Shatila had a medical emergency and was not able to be with us tonight for this session. So I will be delivering the lecture on his behalf. So just allow me to share my screen. So for those who don't know me, I am Maya Zainuddin, a senior clinical pharmacist specialized in neurology, and I am a multiple sclerosis certified specialist by the Consortium of Multiple Sclerosis in USA. I have been working in the multiple sclerosis and neurology field for more than 10 years. I'm also the executive secretary of MENACTRIM, the Middle East and North Africa Committee for the Treatment and Research in MS, and I am the leader of the IVPN NeuroPsychiatry listserv. So my talk today, so it was supposed to be Dr. Shetila's talk, and is about the economic application from multiple sclerosis. So multiple sclerosis is again a chronic disease. It is a disabling disease that will lead to disability if left untreated, and significantly affect the quality of life and the productivity of the patient at their peak age of productivity. So it's a disease of adulthood where the peak age for diagnosis is between 20 and 4 years. And at this age, usually people are at their top or at the top of their productivity. So multiple sclerosis, although it's a very rare condition, so as you can see from this graph, among the 12 most common disorder of the brain or of the central nervous system, multiple sclerosis is here, and it had the second lowest prevalence. But when we look at the cost or the burden of the disease, actually it occupied the second highest cost. So despite its low incidence, it is a costly disease and has a significant burden, economic burden on healthcare system. So this slide shows the healthcare cost of MS. And as you can see, the annual claim cost for MS per patient was estimated to be around $45,500 as a total cost. And when we looked at the breakdown of the cost, you can see that the cost of the medication contribute to the majority of this total cost. So the disease modifying therapy cost will contribute to 63% of the total cost, and the other non-drug cost, inpatient and skilled nurse, the outpatient cost, which is the outpatient visit to the neurologist, professional service, the radiology, the brain MRI, and the ER visit will also contribute to the total cost. But again, the majority of the cost will go to the cost of the medication. So, and cost of DMT was identified actually as a barrier of treatment in multiple sclerosis, mainly because the cost of MS medication or the disease modifying therapy are one of the most expensive medication. And actually this study was performed by the MSIF, and it showed, this is a survey-based study, and it showed that 47% of the MENA countries reported that the cost of treatment is a major barrier to access, and this is in allied with the global average, which is 49%. So again, worldwide, 49% of the country, they report the same issue, and that cost is usually a barrier to treatment. And in 63% of the MENA country, people with MS are required to pay for a proportion of their treatment. So it's not always available free of charge. In most of the country, people have, or patients with MS have to pay a copay, which is usually a big number to get access to their medication. And 1/3 of the countries report patients with MS not taking their offered DMT primarily due to high cost, and this will lead to non-adherence to treatment and probably and most likely disability progression, leading to complete disability and irreversible disability. And most of these untreated patients will be bound to wheelchair after 10 years of being untreated. And also high income country, mainly the Gulf countries, report the fewest barrier to DMT, while the low income countries report the most barrier to access to DMT, highlighting again that cost of therapy is a major barrier to treatment. So this slide shows that also poor adherence is associated with increased medical cost, because when we are not adhering to therapies in MS, we'll have more breakthrough disease, we'll have relapses, we'll have progression of the disease. And this study have shown that adherence to MS therapy will lead to less risk of relapse by 42%, 52% less visit to the hospital, 38% less visit to the emergency room, 30% reduction in the outpatient visit to the outpatient neurology clinics, and 42% reduction in the non-drug medical cost. So adherence to treatment is an important factor to decrease the burden of or the cost of the disease. This is the conceptual model of MS cost categories for economic burden. So as you can see, when we need to study or when we need to calculate the cost of multiple sclerosis, we need to take into consideration the direct cost, which are defined as the medical cost, the physician, the blood test, the prescription, the hospital, the assistive device. Since MS is a disabling disease, most of the patient will require either a cane, a wheelchair, or a walker, or other assistive devices in order to ambulate. And of course, the therapies, the medication. Patient with MS needs symptomatic drug, not only DMTs. Most of these patients have comorbidities. They will need, for example, treatment for depression, for urinary incontinence, for sexual dysfunction, for spasticity. So we have the cost of other medication and the long-term care. Keep in mind that all these diseases are chronic and patients need to be treated and managed for over the long term. And also the non-medical cost, which is the home and auto modification, especially for patients with disability. Sometimes they have to change their home decor, or to add some assistive devices in their home in order to be able to ambulate and to improve their quality of life by adding, for example, escalator, elevator, electronic escalator. In the bathroom, they need some devices in order to avoid falls. And also the transport devices, the formal care and the informal care. We have also the indirect cost, which is the increase in morbidity. We have decrease in productivity in MS, decrease in employment, because MS does not only affect physical, it does not only lead to physical disability, but also to cognitive impairment, and cognitive impairment will affect work performance, leading to high unemployment rate in MS. Also early mortality and impact on the family and friends. The intangible cost also should be taken into consideration when calculating the cost, the burden of the MS disease, and those include the pain, the quality of life, the stress, and the quality impact on family and friends. All the studies from Europe, they showed that MS is really a very expensive disease and it has a profound impact on the healthcare cost. So as you can see, studies from Australia, Austria, Europe, Netherlands, and United States, they all calculated the total cost in dollars for managing MS, and the weighted average turned on to be $41,000 per year. And the cost increase per the disability level. So here EDSS is a neurological exam, so it's a score that usually reflects disability, where 0 to 1 is a patient that has no disability or very low disability. So this patient is fully ambulatory. He doesn't have any ambulation problem or any disability, where a patient with an EDSS of 6 need a walker. EDSS above 6, he will need a wheelchair. So here we have significant disability, and usually those patients who have an EDSS above 6 are non-ambulatory patients and are wheelchair bound or bedridden. So as you can see from the cost will increase with the disability level in multiple sclerosis. But look at something. So as you can see in the early phases of disease where we have low disability, the direct cost of the disease-modifying drug contribute to the majority of the total cost. So really, the disease-modifying drug of the cost will take the big part of the total cost, while whenever we have significant disability and after reaching an EDSS of 5, the indirect cost will take over, and those contribute mainly to the total cost. And this is because whenever we have progressive disease and disability, we will need more nursing care, we'll have more complication and symptoms that needs treatments. And also we will stop in the advanced phase of the disease. Usually we stop disease modifying drugs, and patients are no longer in need of these medication. He is mainly into symptomatic therapy management, and he needs assistance mainly by nurses, physiotherapists, occupational therapists, psychologists, psychiatrists, and this will contribute to the indirect cost. This is a study again from Germany, and also it showed that the mean annual cost for MS management is 39.99 €998. So this is aligned with the other meta-analysis from Europe and from the United States. And again, as you can see, the indirect cost, mainly the long-term sick leave and the early retirement and unemployment, contribute to 40% of the total cost. So really indirect cost also play a major or contribute to the burden of the disease along with the medication cost. So the economic cost of MS is compounded by the age of MS disease onset. So as I mentioned early in my introduction, unfortunately, the onset of the disease of multiple sclerosis peaks between the age of 20 or 40. And at this age, usually all of us or people are at their top or at the high level of productivity. So compared with non-MS, MS has profound effect on workforce, contribution, quality of life, and medical expenditure. So as you can see, the quality of life of MS patient is generally reduced by 10 years compared to a non-MS. There is direct increase in the direct medical cost by 5.1 higher than in non-MS patient, and there is 3.3 times increase in the unemployment rate. This is another study that showed that 50% of the patients with MS are unemployed when they reach an EDSS of 3 after diagnosis, which is almost 10 years after the diagnosis. So we don't have to have a high level of disability to reach a non-employment level. Already at an EDSS of 3, the patient is here still is ambulating well. So he has a moderate disability, low to moderate disability, even though we have 50% of these patients are unemployed. So MS affect unemployment even at low level. And this is the result of a multinational European study of 15,400 MS patients. And MS usually report a rapid decline in the health status utility, even early in the disease course, that usually continue or become worse and progress over time. And mainly the ability to work in MS was impacted by the cognitive decline. And this is very important because cognitive impairment occur very early in the MS disease. From here, the importance of that being of early diagnosis and early treatment in MS, fatigue, depression, and anxiety, because 60% of our MS patient complains of this anxiety and depression, and this will contribute to unemployment. So this is a study, a recent study that was done in Lebanon, and it assessed the quality of life, knowledge, and access of treatment in times of economic crisis. So as you know, Lebanon is going through one of the most difficult economic crises nowadays, and I conducted a study to check if this economic crisis is affecting our MS patients. So the aim of the study was to assess the quality of life among a cohort of Lebanese MS patients and to identify the barrier of treatment during the economic recession. It is a cross-sectional survey-based study that was just conducted recently between June and September 2022. So here are the results. A total of 350 MS patients were included, and the mean music quality of life global index, which was one of the validated quality of life score for MS patients, it showed that patients with older age, low level of education, low income, patient who doesn't have any private insurance and who gets usually their medication or their hospital cost from the government, patient who has other comorbidities and who has physical disability have significantly lower quality of life index by the so lower score on the music quality of life compared to other patients. And unfortunately, 61.7% of our Lebanese MS patients currently have no access to MS treatment due to the economic crisis. And discontinuing treatment due to its unavailability in the Lebanese market was a significant predictor of a low quality of life. So cost affects the availability or the accessibility to treatment, and non-accessibility to treatment will affect the quality of life by increasing relapsing and speeding up the disability progression. So really it's a vicious circle. So our study showed that the economic recession in Lebanon has negatively impacted the quality of life of MS patients and the access to treatment. So moving on to Dr. Ahmed Shatila study from Al-Mafra Hospital, which assessed the cost of MS disease and MS disease management. And again, he was supposed to give this lecture, and I acknowledge that starting this slide, those slides were prepared by Dr. Shatila. The current study will examine MS patients from Mafra Hospital in different age group, and they examine the cost that the patient incur as they follow through the Sahha facility. So this is the methodology. They did, first of all, a literature review. They identified the terms, and then they initiated the data collection by using the ICD-10 code to identify the diagnosis. They also looked at the age, gender, nationality, and clinic visit. They used the Mafra recording system by using the EPI number from Sahha data, and they recorded the age of the patient, gender, nationality, clinic visit, ER visit, admission, medication, MRI, and lab test. They did a data analysis, and also they looked at the cost using the Sahha price list in 2015. The direct costs were defined as the clinic cost, the admission cost, the ER, the medication, the MRI, and the lab test. And the indirect cost was defined in the study as the sick leave for the year of 2016. So this is the first set of the result. So as you can see, 1,097 patients from Sahha and 109 from Mafra were included. The age was between 5 and 92 and 16 to 64 in Mafra. We have Emirati and expat in terms of nationality. We have the 4 different hospitals, Ain, Mafra, Tawam, and Sheikh Shakhbout. The 69.97% of the patients included from Sahha were Emirati, while 40% from Mafra were 43% from Mafra were Emirati. Of course, the majority of patients were female because, as you know, MS is more common in female than male. So the ratio female to male is 2 to 1. And again, they extracted data regarding the outpatient visit, the medication use, the admission, the emergency, the brain MRI, and spine MRI, because this is the diagnostic test, and this is the follow-up test on which we rely in MS to assess the efficacy and the safety of MS medication. So it's usually recommended to perform MRI on a patient every 6 months or at least yearly in order to monitor patient, along with the blood test to monitor for the safety of the medication, CBC, liver enzyme, and vitamin D. So 1,097 patients were identified in Sahha, consisting of 70% Emirati and 30% expat, and prevalence is 38 to 100,000, with a standard error of 6.18 in the total cohort of Sahha patients. So it is a low prevalence. This is the conceptual model of MS category. So we have the direct cost, which are defined as the medical cost. So we have the outpatient clinic, we have the admission, the ER, the medication, again, the MRI and the blood test. And the indirect cost was defined as the sick leave. So here are the demographics from the Saha. As you can see, the majority were in the middle of their age, between 20 and 50, and this is aligned with the peak age for diagnosing MS. The majority were Emirati, 70%, 30 were expat, and the majority were female, as I mentioned, because MS is more common in female to male. In Mafra Hospital, again, we have similar result. The majority were the middle of their age. They were female, and except for the nationality, here the Emirati contributes to 40% of the population, while the expat were the majority, which is 56%. So here are the proportion of services. So as you can mention, the MS patients mainly visit the outpatient clinic, 15.8%, and the MRI departments, 10.8% for a brain MRI and 9.1% for spine MRI, and the blood test, mainly CBC, liver enzyme, and vitamin D, because all our MS medication, they are either immunomodulatory drug or immunosuppressive drug, and usually they cause lymphopenia and increase liver enzyme, and we need to monitor this frequently, and this is common for all MS medication. In this study, Dr. Shatila and his team did also a correlation between the cost and the age, and it seems that we have increased cost with increasing age, and this was aligned from with the international result from international studies. Also, they did a correlation between gender cost and gender, and it seemed that in men use most of the resources in this hospital compared to female, and this is because in multiple sclerosis, although MS is more common in female than male, but men usually have worse prognosis, than a female for MS. So usually men, the disease is poorly controlled in men, and this is associated with more visit to the ER, more admission, more relapses, and more need for medication. And also they did a correlation between the cost and the nationality, and it seemed that the Emirati national, again, they use the resources, and they have increased in the cost of the total healthcare cost in MS compared to expat, and this is because in the UAE usually national have more access to clinic visit appointment and MRI and etc. This study showed that there was an increase in the total cost for MS management from 2010 until 2016, and this is because of the improvement in the diagnostic criteria for MS. This is because we have a new disease-modifying drug, the introduction of high-efficacy disease-modifying drugs starting 2012 in MS, and those drugs are much more expensive than interferon and low-efficacy DMT. Here you can see, of course, again, the medication cost also has significantly increased from 2010 until 2016 for the same reason I was saying, because interferon and low efficacy DMT, they have lower cost than high efficacy DMT. Here you can see that the admission cost mimics the total cost per patient, and significantly increased from 2010 till 2013. We have a decline in 2014, and again a raise starting in 2015, but it started again to decline in 2016, and this is probably because in the introduction of new guidelines, mainly the Menactrum's multiple sclerosis guideline, also regional and international MS guidelines, and also the increase in the awareness and in the educational activity about the treatment and management of the disease, but mainly the introduction of new therapy. Here, the service percentage is out of the total cost. So as you can see, in all years in general, the medication cost contribute to the majority of the total cost. So it is the major part of the cost goes for the medication or the cost of the DMTs. But if you can see, the visit cost is non-significant compared to the medication cost and the admission cost. And again, we have a decline in the admission starting 2013. So it raised from 2010 until 2013, and then we have a decline. And again, this can be explained by the improvement in the management, the guideline, the new diagnostic criteria, and the introduction of the high efficacy DMT in Emirates and in the UAE in particular. And as per Dr. Shatila, he started using those high efficacy DMT starting 2013 for his patients. So by revealing the resources required by MS patient, it will shed the light, this study shed the light on the economic burden and the impact of the disease to the economy of the UAE. This study can also be used to raise awareness by revealing the burden of the disease to the general public and other private and public entities. Financial and psychological support can be offered to MS patients to improve the quality of their lives. In conclusion, the condition of MS in the UAE reveals characteristics similar to this in other countries in the region, but also it mimics the result from international studies. The cost associated with MS has been increasing over time, indicating a continuous increase in the prevalence of the condition in the country. It is highly present in female and middle-aged individuals between the age of 20 and 50. The most expensive service at Mafra was the admission due to worsening patient stage, and it was the highest in 2013, then declined or returned to normal trend with increasing number of patients in the following years, while lab CBC is the least expensive. Admission played a positive correlation with cost of visit and drive more cost for hospital, while medication affect negatively on visit cost. So it's vital that the government conduct educative campaign to educate the people about the disease, the management, train healthcare professional on the guidelines, the need for the importance of early diagnosis and initiating early treatment. Further investigation should be performed on the total Saha or UAE government and private MS patient to get more robust and significant results that can inform effective policy, and we can probably work on this with the expert in pharmacoeconomics, Dr. Sara Dalal. And with this, I will end my presentation, and thank you so much. I hope that I made the job of Dr. Shatila. And just I will check if I can take one or two questions, and then we'll move to Dr. Sara, not to delay her. So one of the question is why female is more affected by MS than man. This is because of hormonals. So due to hormone, and difference of hormone contribute to more incidence of MS in female to male. Also vitamin D deficiency in female than male contribute to higher incidence in female. So this is the only question I can see from the audience, and with no further delay, I will introduce for you as I mentioned, our expert in the field of pharmacoeconomics, Dr. Sara Dalal. Dr. Sara is the president of the Emirates Medical Association's Emirate Health Economic Society. She's a medical doctor who graduated from the UAE University College of Medicine and Health Sciences. She completed her internal medicine residency in Dubai Health Authority, and she holds a master's in healthcare management from the Royal College of Surgeons Ireland and a double master's degree on the health policy and health economics from London School of Economics. She is currently holding a position of Senior Health Service Specialist in the Insurance Policy Development section in Dubai Health Insurance Corporation. Dr. Sara will discuss in her session the role of pharmacoeconomics in healthcare decision makers, the types of pharmacoeconomic analysis used, and the role of pharmacists in applying pharmacoeconomics. Dr. Dalal, we are always honored to have you on board with us. Welcome, and the floor is yours.
Thank you, Dr. Maraya. First of all, I'm so glad to be joining everyone today in this session. And as usual, being part of the IVPN network and being introduced into the IVPN network. Today, you have done, Dr. Samer and yourself, Dr. Maya, have done a great job talking about this. And I don't know where would I come now and how can I pick up from there? But I will make things much more easier because there's a lot to be discussed in pharmacoeconomics and how is it very important to have it. So I would like to encourage everyone to put their chats, to put their questions in the chat, in the Q&A box or the chat box. And if they have any questions, just let's become much more interactive with that. So this presentation will be much more lighter in sense. And I hope that the screen is clear. And if not, please tell me. So today's agenda, we will start with the first part, talking about what are the key health economic concepts. And in general, we are hearing lots about what is cost effectiveness, and is cost effectiveness the only way to see or to really express what could be an economical evaluation analysis in healthcare? And if not, is there something else that could be done? So let's talk about the key health economic concepts. And we will take a look back, and we'll take a look back from a writer or from a very well-known author and an economist. His name is Samuelson, and he said economics per se, if we're talking about economics, is the study of how men and society choose a certain object to employ scarce resources which could have alternative uses. The field of economics relies on decision-making and relies on certain behaviors and relies on how we can make the best use of the resources we have. So most of the time, usually many people will confuse economics with financing. They do work together and interrelate to each other, but economics is more so if I have a certain amount or a budget or resources, how can I use those to best serve the maximum good? So for the maximum amount of society or people, or in this case, patients. There are certain things when we are looking at economics to really look at, which is from the perspective of economics, is either these three broader terms. How scarce are the resources? And in general, the resources are not finite. You have limited resources, but the wants or the demands are very high. You always find that there is a lot of demand, but the sources you have in hand is not matching the demands that is available. So scarcity and the resources are scarce is putting some alternatives, or to justify why you're using a certain object or a certain resource over the other, or a certain medication over the other, or a certain technology over the other. The other alternative, the other perspective is looking at alternatives. And what does that mean? Is that, do we have other alternatives? What if I didn't use this medication and I used that medication? Will it do me good? Will it get to my health outcomes? Will it be the most efficient? So we'll take that into perspectives. And usually economists don't conceptualize cost like accountants, in which cost is a numerical monetary value. So for example, one item may cost $1, but to economists and health economists, they don't look at the monetary value alone and what it brings back to value. As they just mentioned, a dollar is not a dollar. So a dollar to an economist is not a dollar. It's what the value it brings to. And when we're talking about just alternatives, is it the best use of the resource? And is there any more alternatives or the best alternative to use it? And when we're talking about that, we're talking about opportunity cost. Because for everything we use, there's nothing that has been given. There's always something that will be on the account of something else. So if you invest in a certain area, then there are some opportunity costs that are lost in other areas. So for example, if you invest in disease X in a particular non-communicable disease, and you put your funds into a certain area, then you may impact, and there are some opportunity costs that are not going to other areas. And the other perspective that we need to think about is the choice factor. And usually this comes with how you can apply certain preferences. For example, certain individuals may prefer taking the medication in a pill format, while others, they might prefer taking it in a syrup format or in a different format itself, in a formulary itself, maybe in an IM, and that may, or IV, or that may be much more helping them with their daily life, and it's their preferences, and it's one and done rather than a daily dose, and it will help with adherence. So there are things that we have to think about choices. And for a health economist, they have to look at certain factors and put them in a certain way and package them, keeping these three things into mind, the three general perspectives into mind itself. So when we come with health economic evaluation, so why should we do them? Because the question is, if I have a procedure, a service, a medication, an innovation, a program, is it worth doing it? And I should compare it to a certain thing and to the opportunity costs that are foregone. Because as we mentioned, the resources are scarce, but there should be a methodology to really identify that really, do we need that? And how can we need that? And how we can support that? And we need to measure the benefits and the costs. And if it's at some point to see and compare among them, among a certain program to be introduced or not, or certain procedures to be introduced or not, and what are these benefits and costs, whether it was the direct cost or the indirect cost, which preferably we require both of them to be looked at into making a better decision. These are basically the health economic evaluation. So you can do it in a partial way and you can do it in a full economic evaluation way. And the most ideal way to look at things is to do the full part, right? To look at the full economic part, which is the cost effectiveness analysis and the cost utility analysis and the cost benefit analysis, where you're looking both at the cost and the benefit out of it and certain parameters. But at some economic evaluation, they may look at it partially. They may look at maybe the effectiveness or some outcome or some cost minimization analysis. And they only look particularly either at the consequence, which is the outcome or the health outcome, or maybe they will be looking at the cost itself, but they're not combining both. And they're not combining these things into considerations or maybe preferences. But when we're looking at both the costs and the benefits, then you are looking at a full package and a full economic evaluation. Taking that into perspective, as we mentioned, economists, they don't look at monetary values. they look at much more advanced or much more things in terms of only monetary values. And if you go into each one of them, the cost will always remain as a monetary value, as a numerical value, as what is equivalent to a dollar value. But when we are looking at, for example, cost effectiveness and what are the consequences and the benefits, you are looking at other measurement valuations. You're looking at natural units. For example, maybe you're looking at DALYs or QALYs, or disability adjusted life years, or certain quality adjusted life years. And these are looking at, for example, how many years that you are, or how many utilities that you are gaining, or how many years that you will live in a better health if you are at that point. And if that it is compared and adjusted in a way, it will be looked at and measured in a very methodological way that will make the decision much more easier. Now, if we're looking at a full economic evaluation, we're looking at the cost effectiveness analysis as one of them. And let's take that into deep dive and look at what are the methods that are used in a cost effectiveness analysis. So it's particularly a method of comparing the effectiveness of two or more alternatives. So you have a procedure or an intervention X and an intervention Y, and you're trying to compare both the cost and the effectiveness of that. So this is typically used for decision makers to do that. And just before a while, Dr. Maya have prepared and presented the best slides in terms of multiple sclerosis and what are the treatments that are used and how cost effectiveness are used into that in both ways. So the aim of cost effectiveness analysis is to allow decision makers to assess if introducing a new intervention will maximize outcomes, health outcomes, but on the other end, minimize costs. So basically, we're being both efficient and we are tackling the best outcomes and healthcare outcomes for the system. Health economic models usually use various sources of evidences to predict cost and health outcomes. So usually they will look at clinical trials, they will look at other evidences from the clinical trials to really put and plug into economic modeling. And there are also, what makes it quite robust is there's an analysis to look at the uncertainty of it, which will give some robustness that yes, not everything is 100% accurate, but there are certain uncertainties that we have to factor in. And this is usually displayed on a 4-quadrant panel that is cost in the middle graphically with something called an ICER, which is an incremental cost effectiveness ratio. So this visual representation of differences in cost and health outcomes happens between treatments. And we will take into that. So let's discuss what cost effectiveness looks like. And it's usually health outcomes are usually plotted on the X axis. And on the Y axis, on the Y axis is the cost, and the outcomes is on the Y axis. Usually, the original or the first thing represent the current practice. And as we mentioned earlier, cost effectiveness planes is divided into 4 quadrants. So let's go and look at the plane itself. So you plot and you compare the cost and the effectiveness, and then you plot your cost and effectiveness on this plane. Typically, if you are in the north or the first quadrant, which is the top northeast quadrant, then your treatment is effective. but it's most costly, so it will cost you more. But if you are in the southeast quadrant, which is the quadrant in the bottom right, your treatment dominates. So what you have is that your effectiveness is higher and your cost is lower. So it's less costly. So it is the most dominant area where you will have a good value for money. As you can see in these four quadrants, there is a line that is depicted in the middle, which is the maximum acceptable incremental or the acceptable incremental cost effectiveness ratio. And for decision makers and for individuals who are looking at that, this is a ratio that is plotted across this plane to really show decision makers what are their willingness to pay. So anything that is south to the borders of that line means that it's much more dominant and it's much more good for the value of money. So it's typically, as you can see, the quadrant at the southern east or the lower right is usually the one which is much more effective. But you always see that the northern easterner or the top right quadrant is more effective, but much more costly. So if you are plotting, as you can see, this is a cost effectiveness practice, a cost effectiveness analysis in practice. So if it's drug A, for example, is plotted in the northern eastern area, as you can see, which is higher cost and higher effectiveness. So we are showing you the drug A, as you can see in the plane. But let's say if we're calculating the ICER, but for drug A, the costs, for example, is $8,000. But when we are looking at the life years, which is the natural units, is 14.8. So the difference is if you can see the cost is $4, is 4. So $4,000. So when we are looking at the ICER, we are looking the cost of treatment A and the difference between the cost of treatment A over the difference between the effectiveness of treatment A over treatment B. And in this case, we are seeing that there is an 8,000 USD dollars per every life year gained. And if you are looking at that and the concept of how we can look at quality of life and how life year gained is, then we can see that if we plot it, and as you can see, it's plotted here in this diagram, it is in the northern eastern thing. So basically it is in the right quadrant. But what we are missing here is the ICER, which is what is my willingness to pay threshold. And typically the willingness to pay threshold should be less than 3 times the GDP of that country. Now there is another natural unit that are used heavily in the health economic realms, which is the quality adjusted life year. And it's a very concept, which is a genetic measure that looks at disease burden, both in quality and quantity of life. So Nuran Abul Ghabal have mentioned what is an example of a healthcare intervention. Usually you thank you for your question, Nuran. The question is if there is an intervention. So you look, if we go back here in the slide before that, so we are comparing drug A to drug B. And you see that the costs are different. Although drug B is 50% less in terms of cost, and the life year gain is almost similar to the life year gain to a much more expensive drug. So when you are trying to look at the difference and the life year gain, you will put the calculation and you will see that the ICER for this new treatment is 4,000 USD or 8,000 USD dollar per every life year gain. And then you will plot it in this plane and you will say that, for example, a certain drug or a certain ICER, it's coming higher up on that plane, then it might be not cost effective. That's what we are trying to say as an example. I hope, Nuran, the question was answered and was much more clear. Going to the other, we mentioned the life year gained, but also QALY, which is a genetic measure that is also used in cost-effective analysis or cost-benefit analysis, is looking at the quality of life and multiplying it by the length of life. So this is something that is, for example, there is, if you are trying to look at what are the total gain of any QALY. So if you are, for example, a patient is having an illness. So what is the prognosis if you keep that patient without treatment? Is that they will have 2.3 QALYs. But if you bring in a treatment, for example, it will be 5.7. So the total gain in QALYs, if you keep them with or without treatment, what you are gaining with introducing a new treatment is 3.4 QALYs gained, and you plot it on the on a different scale, with quality of life as being 1 at its highest and 0 at its lowest. And you will cross it and see how is the prognosis. For example, if you, as you can see, these are the quality adjusted life years gained. And you can see the step-up approach if you use the treatment. So going back to the example of the cost effectiveness analysis. So there are certain modeling that you can look at with cost effectiveness analysis. And this is based on assumptions or decision trees, or you can see these states, as you can see these round circles, they are called Markov models and micro simulations, to really derive what are the future costs and the health outcomes and what are the incremental costs. So for example, if you look at depression as one of the states, then you will look if you keep them at the usual care or the collaborative care, and based on that, you do a decision tree and plug in all the other factors like quality adjusted life years or death, for example, or whatever it may be. And then you allocate for that a numerical value or a value, and then you try to assess that in its design structure. This will also help for decision makers and for the modelers. And why is this important? Because the role of a pharmacist is to look at these models and to really think that, is it really adding value to the patients and taking them? And as, for example, pharmacists, their role will be looking at this and will be justifying these models if they are done in a proper way, and maybe taking part in them and seeing if really introducing a new medication to a formulary or a drug list, will it help them or it will not? And if the usual or the regular treatments that are available at their formulary or within their hands is giving them best value for their money. So we are talking about value, and why is value really important? But before talking about value into great length, we need to understand, how do we define value? How do we measure value? And how do we allocate value? So these are three broader questions. defining value in general, it's very big and broad. So identifying what constitutes valuable for a patient in society may be totally different what is valuable to a payer in a healthcare system or a decision maker to a healthcare system. But it should be looked at in a way that whatever existing data that you have and methodological approaches that we just mentioned in economic evaluation is best to support that value should be translated in a way that is quite effective. There is a question in the chat box from Amir saying, is cost benefit and cost effectiveness analysis the same? No, they're not. They are looked in a different way. What we have discussed earlier was the cost effectiveness analysis. And during the course of this presentation, we'll be also giving examples of cost benefits. So talking about going back about value and measuring value is quite important. As we mentioned, health economists don't look at the numerical value, but they look at the non-numerical value. So going back to what is value in healthcare, it's not an abstract or a code word for cost reduction. Typically, everybody will think about value, it's some numerical value. It's not about cost reduction. It's a framework that we are looking at the best performance and how we can have the best performance and the best performance and health outcomes for our healthcare system. Do you remember the three questions that we just mentioned earlier? How do we define value? How do we measure value? And how we should allocate value? This is quite particular. As you can see, there's a lot that could be a lot of questions under each question when we define value. And what kind of way that we have to think about when we are trying to define these valuable measures and how we can put them or we can allocate them in whatever, for example, if you are moving towards doing a cost benefit analysis, or if you are moving to do a cost effectiveness analysis, how we can define this value. What are the elements that could be there? What are the decision contexts that could be there? And then if we are looking at, for example, if we are looking at how do we measure it, then which data will we look at? And what are the time frame that you will really look at? And what are the methods that you need to look at? It's always dependent on the data that you have, that you will apply certain methods to analyze it. And after that, after you got the allocation, you will try to shorten out to see, did I allocate that and the cost effectiveness? Will I put that valuable measures and do my sensitivity analysis and look at the least uncertain scenario? And where can I put it and allocate it among these decision makers? These are the three key pillars to think about value and how we can do it. So as you remember, we talked about the ICER, but this ICER or the ICER Value Assessment Framework, ICER is a US entity, is not the ICER incremental formula that we just mentioned earlier. And they look at how they can look at the value of money. And because they looked at it from the short term, can I afford a certain drug or a certain intervention? And they looked at it, if I want to assess the value, I have to look at the long-term value for money? And this is where they look at incremental cost effectiveness and comparative clinical effectiveness. And as you can see, if you are looking at the short term, you look at your budgets and you see if you introduce a new intervention, how will it affect its budget? But if you're looking at the longer term value and the value for money, then you look at cost effectiveness per se. Now the ISPOR chapter or the ISPOR in general, they have identified a value flower. And the value flower, when we are looking at the value of a single medication, it should look at all of this to capture it right. We just mentioned earlier that the cost effectiveness or the cost effectiveness plane looks at costs and a natural unit, which could be a quality of life adjusted years or life gains. Well, for a valuable intervention, you have to think about it in a holistic way and looking at it from different ways also, which at the moment it is very difficult to capture and really know what are cost effectiveness ways that we can do that. And how can pharmacists and other people in the healthcare system really have the role to address that and really address for example, the medication is, although it might be cost effective, but I cannot afford it at the time being, but it is really bringing long-term valuable outcomes to the healthcare. This is an example, but a very simplified example of what could be a value of a drug. And this is for a breast cancer case or a breast cancer treatment. And as you can see, if we try to figure out all of this and put some measures to it, it becomes much more complicated to really address that in, for example, a methodological way. So thinking of a value of a drug, it's not only the quality adjusted life years and the net cost and the cost effectiveness per se, but it's much more complicated than that. And what could help with that, with the quality of life and the measures, pharmacists have a very big role in really capturing multiple elements from this value flower. So why is it very important to look at that? Because decision context and recent value frameworks, they look at it from the patient level, and then they look at it from the insurance level and the benefit package level. So basically, there are multiple ways of analyzing and having a value assessment frameworks. And we are putting in front of you some other areas. So we are looking, as we just mentioned, the ICER from the United States have a framework by itself, but other areas have different payers. And as you can see, there are certain areas where clinicians and for example, healthcare field managers, such as the pharmacists, could play a role of what are the target audience and what are the things that could be done and how we can see at conditions and how we can evaluate that. Yes, we do talk about cost effectiveness analysis and cost benefit analysis, but sometimes it is much more easier to look at the value of treatments from a multi-criteria decision analysis, which is basically part of a lot of criterias that you can keep off and put a value to it, and then you compare it and to compare the net cost and you rank them. For example, if you have multiple drugs that are from the same family, they're doing the same thing, but you want to compare them fairly, then you will look at other things that is valued into that. And it will make, if you want to do more than multiple decisions, rather than looking at cost of one drug versus another drug, but you want to see a whole family of drugs against each other. This is a more simplified way. It might be simplified in implementing, but it's difficult in evaluating if you want to evaluate everything and put weights to that. And you can look at the incremental cost and you can rank them. For example, you can say drug X is much more cost effective than drug Y, than drug Z. And that's why we will take much more deliberative way to see if it's cost effective in a certain setting. This is called, this is called a multi-criteria decision analysis. So Haider have just mentioned what is IVI. And IVI is basically a system. What does it stand for? I will just type it or maybe answer it after that. It's a system that is used or a framework that is used less commonly, but also they use also the multi-criteria decision analysis to really look at how it could be done in a system. Because sometimes decision makers, they will not only look one drug versus the other, and formularies are usually extensive. And that's why in certain areas, multi-criteria decision analysis might be much more simpler to perform and add. So we are looking at now the different ways of ICER valuation, the IS4 valuation, and the list of additional value criteria that might be added when you are trying to evaluate a certain treatment or an intervention. But at the end of the day, there will be, we will go through the final slides, is when we are looking at cost effectiveness, we will be looking at something for decision makers to see if this drug will be enlisted in a formulary or reimbursed by insurance. And we are seeing 5 different systems in front of you. Sometimes the regulator will make the decision that a certain drug should be in the formulary and should be reimbursed. But in certain areas, the regulator will only regulate the introduction of a drug into a market. Then there will be an independent body who will look at the cost effectiveness of it and will produce some recommendations. And then there will be somebody else who will say, well, yes, it's cost effective, but I don't want to keep it, or I don't want to keep it as a coverage criteria in my insurance listing or in my formulary based on what my budget allows and what I do prefer. So you can see different functionalities, and it is very important to have pharmacists being enrolled in the decision making, or maybe even in taking certain decisions, or understanding in which system they fall through and how they can support the system with facilitating decision making. There is an iterative process called health technology assessment, which will look at certain drugs and the assessment and the appraisal. So at one point, you will see the assessment of a drug. So you will get the clinical outcome, as we just mentioned, and the economical outcome, whether it was in the form of a cost-benefit analysis or whether it was in the form of a cost-effectiveness study. And then it will generate a certain idea or a certain formulation, and then it will be pushed to an appraisal team where they will look at multiple factors, as we just mentioned. Is it acceptable by a certain population? Maybe the methods of introduction of this drug is very complicated and it's not acceptable in certain places, or you don't have the experiences although it might be cost effective, but the experiences are not available, then the decision might be altered to a certain way or the other. A big way also of looking at it is budget constraints. Whatever is cost effective may not be affordable. So cost effectiveness does not equal affordability, because as we just mentioned, economists, they will look at how to best utilize certain courses, and having a budget impact is different than a cost effectiveness exercise. So maybe it's cost effective, but it might affect my scarce resources where I do have priorities to spend in some other certain areas. So to arrive to that recommendation, or maybe to a certain thing, there should be addressed in a different value where, as we just mentioned, maybe there are certain ethical considerations to think about, or maybe the efficacy and safety is quite compromised, that certain recommendations will be based upon that. So there are certain areas in the world, and we are just giving examples. So either if there is a new medication that has entered, new innovative medication, in certain places of the world, when they're doing this deliberation and they're thinking, is it cost effective or not? Should I let it be enlisted in the formulary and the insurance will cover it or not? There are certain ways of doing it. So for example, Australia, they have a system where they say, yes, we are accepting this medication to be within the formulary or the insurance will cover it, or no, we don't. But in some other places, they will look at, yes, we will accept only in certain places with a certain restrictions. For example, maybe we will give them to a certain population of patients, or we will give them in a certain areas and will not give in some other areas with a certain restriction, or maybe the restrictions will be for only certain clinical criteria. So, certain multiple drugs, they will have different indications, but the restrictions will say we will only allow it in the indication X, Y, and Z, not all the other indications listed, or maybe in the adult group, but not in the pediatric group. So this what has happened, and as you can see over time, all these countries are starting to get much more better with giving much more insights and doing appraisals and looking at how we can think about. So as we mentioned, positive, negative, and there is positive with the restrictions. So you recommend the coverage with the restrictions or not with restrictions. And each system is different. So as we just mentioned, that Australia is like black or white. Either yes, you enlist or you don't enlist. In Canada, you can have a different system. Either you enlist or you don't enlist, or you enlist with certain conditions. And for example, in NICE, you enlist, or in England or in UK, you enlist and you don't enlist. And then there are certain ways of looking at, okay, we might list you, but you have to have other indications that may differ, and we will look at it in a different way. So by that, I want to conclude the session for today. And I would like to say not everything that is cost effective is affordable, and there is not a unified definition for value in healthcare. And value assessment should focus broadly on the healthcare system and should utilize the best health economic methodologies. And for that to be really transparent, and the assessment results should be reproducible. You cannot do something in one area and you cannot say, well, this is in a hypothetical world, can work, but it cannot work on the ground for our real patients and our real healthcare system. So value is more expensive than price. So thank you so much. And this was the presentation for today. And I am more than happy to take your questions.
Thank you, Dr. Sarah, for, as usual, an excellent presentation. And we will try to take as much question as we can. It's already late, and I'm sure you are tired. So the first question, do you think that in the hospital, in our Middle Eastern region and in the UAE in particular, are we applying pharmacoeconomics when developing hospital formulary?
At the moment, we are not looking at it from a full economic evaluation part, but we are more and more, these sessions are bringing really the idea forward that we need to look at doing things in-house. And for that, we need to have the knowledge and we need to look and compare with other areas. These sessions and what you are doing is quite important because the idea of cost effectiveness, cost benefit analysis is much more important than looking at budgets and only budget impacts. Because at the time being, what most of the regions of the world, they will look at the cost price. They will not look at the value a drug is given or a treatment is given. And for that, we need to do and re-enhance and reinforce in this region to have cost effectiveness being introduced, or even cost benefit to be introduced in our formulary or in our systems. What we are seeing much more refreshing discussion is that the pharmacists right now and the clinical pharmacists started learning more and questioning more, is it cost effective or not? And they might ask or look at the data and research everywhere from other places. But I really, 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 really encourage everyone is not to look at data from other places in the world and make it reproduce, as I just mentioned, and just take it as is and apply it in our countries, because our healthcare system is different and our needs and preferences are different.
Another question, since cost was identified in most of the economics studies as barriers to treatment and to access to treatment, do you think that the introduction of generic drug in chronic diseases and such as multiple sclerosis in particularly would help in increasing accessibility to treatment by decreasing the cost?
Definitely, when you are looking at purely cost, if you are introducing other alternatives, we mentioned with economic value, you are foregoing. Actually, what you are doing is, if you're getting, I'm not saying generics, if I'm getting the same effect with a less costly medication, then this is the most preferable way of doing things, whether it was generic, non-generic. If you're getting the same effect but with the less cost, then this is the most ideal way to go with it, because this is the most cost-effective way of doing things. But again, it's not only about the cost price, it's the effectiveness that we are looking at and the value the drug is giving. So this is the most important thing, is the value the drug is giving, but with the cost attached to it, then you go for that. And this is the most important part, because what you are doing is you're freeing a little bit of your budget to really introduce innovative medication in other places and list more new medications in other areas also, or introduce in non-communicable diseases, maybe curative areas.
And a final question, how do we increase patients suffering from SMA or which is a spinal muscular atrophy or any other rare disease, we increase their accessibility to treatment, knowing that the cost of therapy is very, very high. Like in those diseases, we use gene therapies and genetic therapies. So how can we increase accessibility of those patients to treatment?
Now, it is a very good question. As we just mentioned, like, for example, I'll take the NICE example. If the medication is cost effective, but we don't have the budget, then usually the government will pool certain funds and certain accessibility programs for these patients to get really the treatment that they require. There is also, when it comes to decision makers, there is the way of making business in a value-based healthcare agreement or a value-based agreement. So maybe there are certain agreements that you will pay or you will reimburse a certain pharmaceutical company based on the outcome of the drug that has been given, not on the cost price that they are doing. So these are one of the ways that we can look at the cost, that we can look at accessibility as looking at value-based agreements as one of the ways, or pooling and funding the resources from different areas.
Those were all the questions, Dr. Sarah. Thank you for being with us tonight. And with this amazing lecture by Dr. Sarah, our pharmacoeconomics webinar comes to its end. Thank you, our esteemed speaker, for joining us. Thank you, Jensen, for sponsoring this activity. And the big thank you goes for our 600 attendees for staying with us until the end and until late hours. I would like to remind you that you will receive your certificate of attendance by email within 1 week from today. And if you missed any part of this webinar or would like to revisit any of the lectures, you can check our IVPN Neuropsychiatry library where we post all the recordings. Follow us on our social media platform and stay tuned for our next educational activity, which is scheduled on October 20. Save the date and keep your eyes on our page as all the details will be announced very soon. Until we meet again, stay safe and have a good night.